Hi, you're listening to the recorded lecture for management of patients with urinary disorders. By the end of this chapter, you should be able to explain the factors contributing to upper and lower urinary tract infections, use the nursing process as a framework for the care of a patient with a lower UTI, develop an education plan for a patient who has mixed urinary incontinence, identify potential causes of an obstruction of the urinary tract along with the medical and surgical management of a patient with this condition, apply the nursing process as a framework for care of a patient with kidney stones, and describe the pathophysiology, clinical manifestations, medical management, and nursing management for patients with GU trauma and urinary tract cancers. Urinary tract infections are caused by pathogenic microorganisms in the urinary tract. They're classified as infections involving the upper or lower urinary tract, as well as uncomplicated or complicated. Lower UTIs generally occur from bacteria located in the perineum, and the bacteria moves and is being pushed towards the urethra. Uropathic or uropathogenic bacteria is a bacteria that whenever you get a urine sample with a clean catch void naturally shows up. So if you don't have, and it's more in females than males, if you don't have your patient clean well enough, then they'll get the bacteria that's actually outside the urethra instead of inside in the urinary tract. Women have a shorter urethra than men, so that's why they have urinary tract infections more than men do. There are two types of reflux that also can contribute to UTIs. There's the urethrovesical reflux and ureterovesical reflux. So one involves the urethra. So the urethrovesical reflux is whenever you cough, sneeze, or laugh, what you're doing is causing pressure and release of the urine into the urethra. And then whenever that pressure stops, the urine will come back up from the urethra into the bladder. So if there's any kind of bacteria in the urethra, it gets pulled back up into the bladder. The ureterovesical reflux is when urine is pushed into the ureters during voiding. So the sphincters that are generally here that stop the urine from going up into the ureters whenever you void, they're weakened, and so you actually get that reflux back up into the ureters during voiding. And then whenever voiding stops, the urine will flow back down into the bladder. So the urine can actually carry bacteria up into the ureters, and then you get urinary stasis as well because that urine went back into the ureters instead of being expressed out during voiding. Early symptoms of UTIs include burning, itching, urgency, and fever. Some older patients will develop incontinence and confusion at the onset of the UTI. So if you have a patient that comes in and they're older and they're confused, most of the time they'll do a urinalysis and culture to see if they have a UTI or not. Females more than males will get UTIs earlier in life, but as you get into the older adult ages, that female to male gap actually narrows. And this is because older women generally don't have as many sexual encounters as they do when they're younger. And then men will develop BPH, and that can cause urinary stasis, which increases their chance of getting urinary tract infections. Major goals for patients with UTIs: if they have any pain or discomfort, you want to relieve the pain or discomfort. They might not have any pain or discomfort, just might be going to the bathroom more often, so they'll have frequency and urgency, and those might be the only symptoms that they have. So the main thing is to teach them preventative measures so that they don't have UTIs. Okay. If they do have pain, they can get analgesics. They can have warm sitz baths or warm washcloth to the area because that can help. You want the patients to drink a lot of fluids. Water's the best choice, but anything that's non-caffeinated. And that will help to flush the bacteria from the urinary tract. They need to void every 2 to 3 hours, and that is so that the bladder can be emptied and it's not just sitting in there, especially if there is bacteria in the urine. You want the clients to shower rather than bathe, because bathing, there's an increase in UTIs with bathing because you're just sitting in that water. They should avoid anything with caffeine in it, anything that's really spicy, alcohol, Coke, citrus type fruits and fruit juices. And they need to wipe from front to back if they're females. So if you have a patient who comes in frequently for being treated for UTIs, ask them how they clean themselves, how they do pericare, or watch them. Sometimes they go back to front, sometimes they go back and forth and just kind of scrub the area. If they have some kind of incontinence pad and they don't change that every time they void, then that urine can sit there and the bacteria can grow and go up in the urethra, and that can cause an infection as well. Women who are sexually active should void after they have intercourse, because intercourse can push the bacteria up into that urethra. Urinary incontinence is very common. It is underreported because it's embarrassing. It affects men and women, and then there are different types. Stress incontinence is an involuntary loss of urine from sneezing, coughing, or changing position. Urge incontinence is an involuntary loss of urine associated with strong urges to void that cannot be suppressed. So you feel like you have to go, you just can't get to the bathroom in time. Functional incontinence, there is nothing wrong with the lower urinary tract as far as the function goes, but there are other factors that make it difficult for the patient to identify the need to void. So if you have a patient who has Alzheimer's or dementia and they just don't know that they have to void, that would be functional incontinence. Iatrogenic is involuntary loss of urine because of extrinsic factors. Generally, that's medication-based, and it causes relaxation of the sphincter and the pelvic floor muscles. Mixed incontinence is whenever there's multiple types of incontinence involved. So you might have stress incontinence and urge incontinence. Patient education is the key for urinary incontinence so that you can try and treat it and get it controlled as much as possible. You can try education verbally and in writing. Research does show, however, that written and verbal instruction is usually inadequate to teach individuals how to strengthen their pelvic floor muscles. So biofeedback assisted pelvic muscle exercise is actually better than doing verbal or in writing education whenever you're trying to teach those types of exercises. And the biofeedback assisted exercises actually use electromyography to help the individual identify pelvic muscles that they're trying to attempt to contract and relax. And some of the different apparatuses will actually give a very light electrical shock to the muscle and cause it to contract passively rather than the patient having to actively contract the muscle. They also have cones that are weighted that can be inserted into the vagina, and they're supposed to be held there by the muscle and then released. Medications can be used to help with incontinence. Timed voiding, bladder retraining can also help, especially if a patient has an indwelling catheter and they've had it in there for a while and then it's removed. The sphincter becomes relaxed, and sometimes patients can have urinary retention. So it's really good to get them on timed voiding and bladder retraining programs. So what you do every 2 to 3 hours, the patient is instructed to void, regardless of if they feel like they have to or not. And after they're done voiding, you assess the bladder to make sure that they have not retained any urine and there's no urinary retention or stasis. If they do have urinary retention, then you need to call the doctor and let him know, and he'll decide what to do. You don't put the catheter back in. Generally, that will improve as long as they're well hydrated. For bladder retraining or timed voiding, first thing in the morning, get up and go to the bathroom and make sure the patient tries to void. Before each meal is a good time to try and get the patients to void, because they can void and then wash their hands and they're ready for their meal. And then whenever they get ready for bed, again, they can void, go to the bathroom, and then wash their hands, brush their teeth, do their bedtime routine. And then if they have to get up during the night because they're incontinent at night, they can set a timer and get up and go to the bathroom at night. Urinary retention is something that does occur, and it's whenever the bladder does not completely relieve itself of urine. In adults older than 60 years of age, 50 to 100 milliliters of residual urine can remain after each void, and that's because of the muscle not being as strong as it used to be, so they're not able to push all of that urine out and empty that bladder completely. Nurses should encourage normal voiding patterns, especially whenever in the hospital, and that will help with urinary retention. Some people just are shy. They have shy bladders. They don't like to go whenever they're not at home. So they need to be encouraged to void. And that's when you can tell them, hey, every 3 to 4 hours, get up and go to the bathroom anyway. Before each meal, get up and go. Before you go to bed, when you first get up in the morning, just get up and try. You can give them privacy. That tends to help. You can help them up to the bathroom so that they're actually sitting upright on a toilet. You can get a bedside commode if they can't get to the bathroom. That way they're not trying to use a bedpan, because using a bedpan makes it even more difficult. It's not natural to sit in a bed and try to go to the bathroom. Try and give them as natural of a setting as you can. If they do have to use a bedside commode, pull the curtain, close the door, give them as much privacy as possible. If they do have to use a bedpan, try and get their head up as much as possible and get their feet down so they're in what mimics a sitting position as much as they can. And that can help with urinary retention in the hospital as well. Urolithiasis or nephrolithiasis, those are basically just stones. The stones can be lodged in the ureter, or they can be in the kidneys, they can be in the bladder, they can be anywhere from the bladder until they're expelled. But stones that are lodged in the ureter can cause ureteral obstructions, and this will give acute, excruciating, colicky, wave-like pain. It sometimes can radiate down the thigh and into the genital region. The clients do feel like they have to void, but they're not able to void at all. And if they can, it's very little, and it does include blood. And that's because any type of stones are going to be very rough and abrasive, and they tear at the inside of the ureters and the urethra and the bladder, causing bleeding. The symptoms of excruciating wave-like colicky pain is called ureteral colic, and it needs to be treated because the patient can have actual physiological symptoms from that. So you will most likely, as the nurse, be giving them some type of opioid analgesic to help with the pain. So there's all the different sites for urinary calculi. In addition to opioids, you can give the patients NSAIDs for pain, and it helps to relax and get rid of some of that inflammation as well. You will want to increase fluids. Most of the time you'll give them normal saline because you're trying to push that stone through the urinary system so that it can be expelled. You will strain the urine to catch the stone, and then the stone can be sent off to see what type of stone, if it's calcium based or if it's uric acid based. If it is calcium based, then the patient can be put on ammonium chloride or thiazide diuretics. If it is a uric acid based, then they'll just be put on a low purine diet. They can also be put on allopurinol, but they need to avoid shellfish, anchovies, asparagus, mushrooms, any type of organ meat. If you want to treat renal stones rather than letting them pass, either they're not passing or the stone is too large for them to pass, then they can actually go in and break the stones up or retrieve the stones. So in this first image, the physician is using a scope. So they're taking the scope and inserting it into the ureter, and then a laser is inserted after that, and the stone is destroyed using the laser or ultrasound waves. They can place a stent in the ureter to keep the ureter open or the urethra open while they're waiting for the stones to pass, and then the doctor will go in and he'll just pull the stent, and that can be done in the doctor's office, the pulling of the stent. You can also have a non-invasive procedure, ESWL. It's basically you can see the x-ray, and then it will display on the computer screen to locate the stone. And then once the stone is located, they'll have shock wave pulsations that are aimed at the stone that will break up the stone. And then as the patient voids, the broken up stone fragments will be expelled in the urine, and you'll strain that urine as well. You can do endourologic procedures to extract the kidney stone if it cannot be removed by other means. So if it's too large, if it is actually obstructing to the point where no urine can pass, or if the patient is having other complications because of it, then they can actually go in percutaneously and grab using forceps or a basket and scoop out the stones. As far as patient education, they need to know signs and symptoms to report, whether they have passed a stone or they had a procedure done. They need to notify the physician immediately if they have urinary retention, if they're not able to void, if they have any signs of a UTI or an infection. That needs to be reported immediately so that they can get treatment. They need to make sure they have follow-up care, especially if they have recurrent stones, so that can be monitored and the stones don't get too large. They can do urine testing at home if it's something that the physician wants them to do. They need to do what they can to prevent recurrent stones. So they need to drink plenty of fluids. They need to go to the bathroom every 2 to 3 hours. And they need to make sure that they limit their consumption of coffee, tea, soda, alcohol. They really need to stick with water. And then citric juices are higher in calcium as well and can be a little bit irritating. So they really do push water. I know patients don't like water, but flavored water, anything that doesn't have caffeine in it, is not carbonated, is generally a good thing for them to drink. If it is a uric acid based stone, then they need to follow the low purine diet. If they are sent home on medications, they need to be educated about the medications. If they're sent home on an antibiotic, they need to be educated on the importance of completing that antibiotic, whether they feel like they have an infection or not. If they do have a procedure and they develop a fever, that is not normal and indicates a UTI, so they need to notify the physician immediately. Patients can also have GU trauma. Urethral trauma can be anything from a contusion to a complete transection of the ureters. If they have bladder trauma, it can be a contusion or a rupture of the actual bladder sac itself. And then urethral is blunt trauma to the lower abdomen or pelvis. And these patients generally are not able to void, and so because they can't void, there's no place for the urine to go and the bladder becomes distended. and it can be extremely painful for them. Trauma management, control the pain, control the hemorrhage. If there is a hemorrhage, try and prevent infection. Make sure that they're able to expel the urine. And if they do have a puncture in the bladder itself, then that can cause peritonitis. So they need a monitor for that. They can have a suprapubic catheter. They can go in and surgically repair the bladder and have an indwelling catheter. It just depends on the type of injury, the severity of the injury, and what the physician and patient feel is the best for management. As far as the nurse, you're going to make sure that the patient has adequate pain control. You're going to do frequent assessments, make sure that they're not hemorrhaging, they don't have a sign or symptom of an infection, that they're not going into shock. If they do need surgical intervention, you're going to do incision care, make sure it's clean and dry, no signs or symptoms of an infection. Make sure they get adequate fluid intake so that you can flush out that urinary tract system. Urinary tract cancers can happen in the kidney, the bladder, the renal pelvis, the ureters, or the prostate, which actually is around the urethra for males. And treatment depends on the type of cancer, the progression, where it's at, and what types of signs and symptoms that they're having. Generally, they have painless hematuria. They can have pelvic or back pain if it is metastasis or if the cancer is progressed to the later stages, but generally earlier stages it's painless. Diagnosis, they can get a CAT scan, an MRI, a PET scan, ultrasound, ureteroscopy, and they can actually biopsy if they need to. They can get chemotherapy, radiation therapy, and then surgical management. So they can go in and they can remove and resect. And then the BGC treatment is where they actually go in and introduce a pathogen, and that is done after the resection is done. The cystectomy, they can actually remove the bladder, and then they'll put in a urinary diversion device if it's bladder cancer. As far as nursing management, if they do have surgical interventions, you're going to monitor urine output hourly to make sure that they have sufficient urine volume and their kidneys are still functioning. If they have an ileoconduit or some kind of stoma, then you're going to make sure that you monitor stoma care. They have good skin care. If they have a surgical incision, you're going to do the surgical site care as well. Again, encourage fluids. You will have to treat them holistically. They will have some self-esteem, self-image issues that they'll have to work through, and you can help them with that. They'll need education and longer-term education and treatment on how to manage their stoma and ostomy site, how to apply the appliance and whatnot, and a wound and ostomy nurse will be assigned to them to help with that as well. These are different types of urinary diversion devices. This is your ileoconduit. I lost my little, that is so hard to see. It's like this little pinpoint. So ileoconduit, they actually, right here, take part of the bowel and they remove the bladder, and then the ureters get attached to the ileoconduit. And then that gets brought out to the outside of the abdomen where you see a stoma. They can also do something called a cock pouch. And this is the reservoir. The patient will have a little bitty hole right here, and they will actually, it's a sphincter. And so they'll take and they'll insert a straight cath and empty that reservoir. And then they remove the straight cath. And then this area here closes up because of the sphincter. So they straight cath themselves, but through the peritoneal wall or through the abdominal pelvic wall. And then they can also have an Indiana pouch, and this is the Indiana pouch. It is lower than the stoma, and with this, you also would take a catheter, insert the catheter, empty, and then remove the catheter. If they have the ileoconduit with the stoma coming out, like this one here, they will have an ostomy bag for urostomy that will drain. So this requires a urostomy bag or external appliance. The cock pouch, the Indiana, does not require an external appliance, but they do have to straight cath to empty that. So I can write Indiana pouch. There you go.